than normal. Usually this is more than 3 millimeter, and they are tortuous. That means they are taking different directions. They are the tortuosity is meaning having many curvatures, having many curvatures. These varicose veins mainly affect the great saphenous vein in 6% of the cases, while 20% involve the small saphenous vein. Okay, and these varicose veins are classified into primary and secondary. Primary varicose veins, usually here the cause is unknown. The cause is unknown, and usually the problem here are in the valves, which I have just mentioned. The valves which guard the direction of flow between the superficial and deep systems are incompetent, or they are not functioning well. So that blood reflux back from the deep system into the superficial system, and this will result into engorgement and filling of the superficial veins with this back pressure. Eventually, this will result into dilatation of these veins and tortuosity. The secondary varicose veins are due to obstruction of the deep venous system. This usually results into secondary varicose veins. So, for example, if you have got a deep venous thrombosis or thrombosis in the deep venous system, blood cannot flow to the heart, and this will create a back pressure, and eventually this will result into engorgement of the superficial veins, leading to some sort of varicosity. Okay, so primary varicose veins, usually the cause is unknown, and the problem is in the valves, in the perforators, which govern the flow between the superficial and deep system, while the secondary varicose veins are usually due to obstruction of the deep venous system. For example, in case of deep venous thrombosis. I think you have seen some patients who have got small black veins, like hairy veins. You may have seen this in yourself, or probably in one of your relatives, or probably in one of your family members. Small hairy like black veins, and these actually are not varicose veins. These are not considered as varicose veins. These are considered known as telangiectasia and reticular veins. Okay, so they are not typically dilated, like more than 3 diameter in their diameter, and they are not tortuous. We don't call these varicosities. These are known as telangiectasia and reticular veins. So they are not varicosities, but still they indicate that there is some degree of venous hypertension that the patient is having. And I will show you a picture showing telangiectasia and reticular veins. Yes, please look at this now. Look at this picture and show me what do you see here on the left side of this screen.
Superficial saphenous vein dilated.
Yes, there are multiple dilatations. And this tortuosity, I mean, taking different curvatures, right and left, and so on, like that. In Arabic, we can call it تعرج. No, التعرج. It's very clear, and also very clear here. But this is known as tortuosity, and this is as you have seen, involving the medial aspect of the calf or the leg, and this actually involving this great saphenous vein. And now, what do you see here? This is the posterior aspect of the thigh. Yes. Yes. So there are some varicosity, which in this case is involving the small saphenous vein, because this is mainly on the posterior. It could be extending on the. It looks like extending above the knee, and so probably also here some venous tributaries above the knee. And here, this is typically the tortuosity. This is typical tortuosity of varicose veins. And what do you think? Which saphenous vein is involved by this varicosity or varicose disease?
Great, doctor.
This is the posterior aspect of the of the leg, of the calf area. So this is most likely the small saphenous vein. Okay. Yeah. So this is how varicose veins typically look. This is how varicose veins typically look. And as I have said, the problem is that the blood is not flowing normally from the superficial system to the deep system. Either there is a problem in the perforator's valves, which allow the blood to reflux back into the superficial veins, or there is obstruction in the deep venous system, which is again creating a back pressure that results into filling and dilatation of these veins. Okay. Regarding the epidemiology and risk factors of varicose veins, the disease actually is common among the adults. It's very common among the adults, particularly those who, for example, due to their jobs or due to their lifestyle or for any reason, those who stand for a long time. It has been found that those people who stand for a long time, they are more prone to development of varicose disease. The risk factors include the age, and the disease is actually more common in elderly patients. Usually, the incidence increases significantly with advanced age. Gender again has got an important role, and the disease is more common in females than in males, particularly around the age of pregnancy and childbirth. Obesity is a risk factor, and this may explain why females are more prone to the disease in comparison to males, because we know that females tend to be more obese than males. Pregnancy, because the gravid uterus causes some impedance of venous flow from the lower limbs up to the trunk and toward the heart. So the gravid uterus here may cause some impedance for venous flow from lower limbs toward the heart. Some patients are expected to have a positive family history, because there is in some patients you find one or more of the family members are affected by the disease. So family history is important. As I have mentioned, people who tend to stand for a long time because of their occupation or their work, they tend to have an increased risk of development of these varicose veins. Now, these risk factors are important because if you are consulting or, for example, seeing a patient who have got a varicose vein, then you have to review these points in your history. You have to review these points in your history, because all of these are directly related to the risk of development of varicose veins. The pathophysiology of this condition, as I have mentioned, is not well known. So there is some hypothesis. There is some hypothesis which explains why people develop this varicose vein. One hypothesis indicate that due to some inflammation or inflammatory infiltration of veins, you get deposition of collagen, and when you get this collagen deposited on the wall of veins, particularly perforators, then you get loss of elastin and loss of elasticity. The vein will lose its elasticity, and this will result into elongation. If the vein gets elongated or gets longer than normal, then it can become tortuous. Now, this elongation and tortuosity, which is secondary to some degree of inflammation and loss of elasticity, will result into valve dysfunction. This will probably stretch the valves, and the valves will no longer be able to function normally. So when you get this valve dysfunction, secondary to this elongation and tortuosity, then the blood can flow back, as I have mentioned, and then you can get dilatation and varicosity of the superficial veins. If I want to, for example, draw this like if this is a perforator connecting the superficial system to the deep system, and then you get the valve here, you get a one-way valve here, which governs the flow only in this direction. Okay, so if you get elongation, if the vein now becomes longer than normal because of this inflammation, deposition of collagen, and loss of elasticity, and particularly if it becomes tortuous like that, This might come at the level of the valve, and then what will happen, instead of having the valve competent here, is very competent, not allowing blood to flow back. Here the valve will be incompetent, and this will allow blood to flow back from the deep system into the superficial system, and this will result into a tortuosity. So this is one theory explaining the pathophysiology of varicose veins is due to valvular dysfunction in the perforators, which connect between the superficial system and the deep system. The other, this is actually for primary. For the secondary, as I have mentioned, this is secondary to something, and usually secondary to obstruction of the deep venous system. So if the blood, yes, if the blood is not able to flow up to the heart, then the blood will stagnate here, and this will create a back pressure. This back pressure will be transmitted to the superficial system, resulting into dilatation, tortuosity, and varicosities of this superficial system. Okay. Yes. So one question here is that blood tends to pool. Blood tends to pool down in lower limbs, and if the body have no system to guard against this stagnation of blood in the lower limbs, then you can get venous hypertension, and everybody will be prone to development of venous hypertension. So how does the body guard against pooling of blood in the lower limbs and venous hypertension? Yes, please.
We have the peripheral heart, the gastrocnemius, which pumps the blood to the heart.
Okay, so this is one thing. This is one important factor, and this explains actually why people who do not move for a long time, or who are bedridden for a long time, why they are prone to development of thrombosis and venous hypertension. Yes, this is one thing. What else?
Venous suction of the heart.
Yeah. This is, yeah. You mean the respiratory pump? You mean the respiratory pump? Yes. During inspiration and respiration, yes, this will accelerate the flow from down to upwards. Yes. What else? The presence of valves. No, the presence of valves. We know that we have these valves in the veins of the lower limb, but we don't have these valves in the veins of the upper part of the body, head and neck, because in the upper part of the body, gravity will accelerate or foster the movement of blood towards the heart, while in the lower limbs we have to have these valves so that blood does not reflux back. This is how the body guard against venous hypertension in the in the lower limbs. So regarding the clinical presentation of varicose veins, actually the spectrum of clinical conditions is actually wide. Some patients, they only complain of some discomfort and heaviness in the lower limbs. Some in moderate cases, some patients may have pain, burning pain, itching pain. Sometimes they may have pins and needles, like these things. So pain actually ranges from only discomfort, heaviness, to distressing, sometimes burning pain and itching. And the disease tends to be bilateral more than unilateral. And actually, this is one of the characteristic features of venous disease, which might help you also to differentiate between the differential diagnosis or other condition that might result into lower limb swelling. So these are regarding the symptoms. Regarding the signs, in addition to the varicosities, and which are dilated and tortuous veins, some patients might present with pigmentation. You may see, for example, blackish discoloration or dark. You might find the dark skin around, involving these varicose veins and around them. And actually, this pigmentation is known as hemosiderosis. And the explanation for hemosiderosis is that in these dilated veins and tortuous veins, you get stagnation of blood, and this will result into sometimes into hemolysis. When you get hemolysis, then you get heme. heme will come outside of red blood cells. We know that heme is found inside red blood cells. One of the constituents of this heme is iron. We already know that iron has got an important role in generation of cells. So this iron will start to be deposited in the skin and subcutaneous tissues, in these varicose veins and around them, and this pigmentation secondary to iron deposition in tissues is known as hemosiderosis. So pigmentation is one of the classical features of varicose veins or venous disease in general. Some patients develop, when the condition becomes chronic and is there for a long time, they develop some subcutaneous inflammation of the skin and subcutaneous tissues, and this results into thickening of the skin and subcutaneous tissues, particularly involving the fatty tissue in the subcutaneous space, and this condition is known as lipodermatosclerosis, which is actually thickening of the skin and subcutaneous tissue. In the late stage of the disease, usually patients they develop venous ulceration. This venous ulceration usually happens in the lower medial aspect of the leg. And this area is particularly known as the gaiter area. This area is actually found between the muscles of the calf and the muscles of the ankle. So where does it lie? It lies in the lower medial aspect of the thigh, just above or around the medial malleolus, This area is known as the gaiter area, and this is the commonest area in which you get venous ulceration. Venous ulceration is not expected to be found in the foot, neither above the gaiter area. Okay, if you found ulceration, as mentioned in the textbook, if you found ulceration in the foot and ulceration above the gaiter area, I mean involving the upper part of the leg or even the thigh, then think of another diagnosis other than venous disease. Okay, so ulceration due to venous disease is usually found in this gaiter area, and the explanation is that in this gaiter area, there are perforators. There are many perforators which connect the superficial system to the deep system, as I have mentioned earlier. These known as the cockit perforators anatomically. And when you get incompetence of these cockit perforators, then you get ulceration in this area. We have already talked in previous sessions and other lectures about the characteristic features of venous ulcers on examination, and I think we don't need to repeat that now. Actually, when you get swelling of the lower limb, particularly in cases in which this swelling is massive, then this will impede even the arterial blood flow into the lower limb. Okay, so this swelling of the tissues superficially and deeply will create a pressure, will increase the pressure in the lower limb, and this can eventually impede even the arterial inflow or blood inflow into the lower limb, and eventually those patients can, secondary to this venous disease, can also develop arterial insufficiency, and this is known as venous ischemia. Why it's called venous ischemia? Because the ischemia, which is arterial, is actually due to swelling in the lower limb and increased pressure within the lower limb secondary to venous disease. Okay, so in this case, venous disease may result into ischemia. So this is one point that you might put that you might need to consider if you are dealing with those patients, that sometimes venous disease and arterial disease, they can coexist. Venous disease and arterial disease, they can coexist. What I mean by that, that in the same patient you might find venous disease as well as some manifestation of arterial disease. Okay. Yes. So here in this picture, I'm showing an important clinical test, and this test actually aims to identify where are the incompetent perforators? Where are the incompetent perforators? This test is known as the Trendelenburg test. This test is known as the Trendelenburg test, as you can see here. So this is the physical or clinical test that you usually do to identify the perforator. So what do we do here? As you can see here, now this the physician is elevating the lower limb, which is affected by the varicose veins. He is emptying the veins back into the deep system, okay? And every time he control one group of perforators. So, for example, here he is controlling now pressing here in the perforators above the medial malleolus, and then ask the patient to stand and look. If the patient develop varicosity, then most likely these veins are not affected because they are occluded. These perforators are not affected. Now, after that, he do into the group of perforators above that level. For example, below the knee, empty the varicose veins, control or press on these perforators, ask the patient to stand. Here, standing because gravity will help the blood to fill the varicose veins. If the doctor is occluding these perforators and still the patient develops varicosity, that means the problem is in the higher than this level, and he goes one by one like that until he reach where the saphenofemoral junction here. So he empty the lower limb like that, and then he occlude the saphenofemoral junction, ask the patient to stand. Now, if the patient did not develop varicosities while the doctor is controlling the saphenofemoral junction like this, occluding the junction like that, that means the perforators lies at this level. Okay. So the Trendelenburg test is the physical test which will enable you to identify where are the incompetent perforators, which result into varicose veins. Okay. So this is just giving you an idea about the test, and perhaps if you find the chance, we will do it practically to show you how does it help you to identify the incompetent perforators. If the idea of this test is clear, please. Is the idea of this test is clear? Can you hear me, please?
Can you just...
Now, if the patient have got varicose veins, there are possibilities. Where are the incompetent perforators? It could be here at the level of just above the medial malleus, or maybe here in the other group, or maybe below the knee, or maybe above the knee in the middle of the thigh, or maybe where in the saphenofemoral junction. How would you know where are these incompetent perforators? Because this is important if you want to treat the patient, because this will tell you which group of veins are not functioning well, so that you can plan your surgery. So the idea of this test, is to allow you to identify where are the incompetent perforators. So for example, suppose that you elevated the limb like that, and you squeezed the limb, you empty all the varicose veins, and you occluded the saphenofemoral junction, and then you ask the patient to stand. Suppose now you get, like in this patient, like still you get varicosities. What does this mean? We are occluding the saphenofemoral junction, and still there are varicosities. What would this mean? Anybody? Yes, Ali. What else? Who? No above, actually. No above. It should be where? Somewhere below. Because this is the higher level. Yes, this is the higher level here. So that means the perforators that means the perforators are lower than this level, not at the level of the saphenofemoral, because we are occluding here, and still there are varicosities. So what do we do next time? Again, we elevate the limb, we empty the veins, and then we occlude the lower group here, for example, in the middle of the thigh. If the patient again developed varicose veins, that means the varicosities are lower down. Okay, so this is the idea. This Trendelenburg test will allow you to identify clinically the most likely site of incompetent perforator, so that you can plan your treatment accordingly. yes, safe.
دكتور هذا التست فقط لبرايمري varicose.
Is not necessary for the yeah, it's mainly useful for the primary. Yes, I would say it's mainly useful for the primary, because for the secondary the problem is not in the perforators. For the secondary the problem in the deep venous system. Okay, but this will allow you to identify where are the incompetent perforators between the superficial and deep venous system. Okay. Here are some pictures that I would like you to see and tell me what do you see, or if you can describe. I would like to start by this. What do you see here? This patient have got a venous disease. In addition to that, what do you see?
Discoloration.
Yeah, there is dark pigmentation of the skin. And what do you think? This dark or pigmentation or dark color. Yes, and this is what we call hemosiderosis, which is due to deposition of iron, as I have mentioned, due to hemolysis. Yes, this patient again here have got a venous disease. And can you describe what do you see here?
Thickening of the skin.
It's obvious that the skin is looking unhealthy. This is quite obvious. There are areas here which looks whitish like fats, and you have got thickening of the skin. This is very clear, and this will result into skin fibrosis and subdermal fibrosis, and the skin will be tough and like that. This condition, the thickening of the skin and subcutaneous features, is known as lipodermatosclerosis. What do you see here? Some sort of redness here, some sort of inflammation. Yes. So sometimes the patient might present with eczema. Sometimes the patient might present with inflammation which mimic eczema. This is one of the presentations. Okay. Here, lower down here, again we can see some sort of pigmentation. Yes, Abdul Karim.
So is it associated with itching?
Yes, itching and pain. These are the classical symptoms of varicose veins and the complications of venous disease. What do you call this area, please? What do you call this area?
Gator, close to the pony prominence.
Yeah, this. Yes, as you can see, this is the lower medial aspect of the lower leg or the leg. Lower medial aspect of the leg around the medial malleus, and this is usually the gator area. The gator area, which is the most common site of venous ulceration, it happens in this area. Now, tell me what do you see here. Tell me what do you see here. Describe what do you see here, please.
Tortuous of the small vein.
Exploration of superficial small veins.
But it does not look dilated as what for example, as what we have seen here. You see in this slide. Yes, you see in this slide, these are very obviously dilated and tortuous veins. But this does not look like that. No, these are hairy.
It's like hairy projection.
Sorry.
So, venule move in.
Yeah, these are hairy venules, small venules. They are not dilated, and they can only be seen in the subcutaneous space in patients who have got fine or white skin. Yes. So these are not considered as varicose veins. These are known as telangiectasia or reticular veins. Whenever you see something like that, and we do have ladies coming to the hospital, to the clinics, complaining of these conditions usually, because ladies are more prone to venous disease than males because of obesity. So whenever you see something like that, this is not considered as varicose veins. These are known as reticular veins or telangiectasia. They are not varicose veins. However, they also indicate some degree of venous hypertension. And people who have got these reticular veins, in the future they can develop varicose veins. In the future they can develop varicose. So this can be alarming. This can be alarming for you as a physician, that the patient have got some degree of venous congestion or venous hypertension, sorry, and in the future he is prone to develop some varicose. So this is the ideal time to advise the lady, for example, or the patient to reduce weight and maintain good life style, like doing exercise and observe her diets and avoid standing for long times and so on. Okay, so this is the importance of these reticular veins and telangiectasia. Now, in this picture, you see what here there are these are ulcers, venous ulcers, and as I have mentioned that venous ulcers usually are encountered in the gaiter area. But tell me, what do you see here? Tell me, what do you see here? In this patient have got a venous disease and venous swelling, and he's showing these features.
Complicated, Doctor, arterial insufficiency.
Yes. No, describe what do you see, Terry Support, please. Describe what you see.
Doctor. Well,
Yeah.
Black discoloration.
There is black discoloration. What do you call this?
Accumulation of air.
Gangrene يا دكتور.
Yeah, this is gangrene. This is gangrene. So what do you think this patient developed? What do you think this patient developed?
Red milk. Signs of inflammation يمكن.
Sorry?
Inflammation.
Okay, another idea?
What gangrene يا دكتور؟ عشان
No, I mean, what is the cause basically? What is the cause of this gangrene?
arterial insufficiency.
Arterial insufficiency. Yeah. Secondary to the venous swelling, the pressure increases significantly in the lower limb, and this will impede or decrease the arterial inflow to the lower limb, and this will can result into ischemia. So what do you call this type of ischemia, which is secondary to this venous congestion? As you can see here, we call it what? A venous gangrene or venous ischemia. This condition is known as venous gangrene or venous ischemia, indicating that the primary abnormality is not in the arteries. The primary abnormality is in the venous swelling. Venous swelling actually resulted into this condition. Okay. So so far we have talked about the definition of varicose veins. We talked about classification of varicose veins into primary and secondary, and we identified the reason or the cause or the etiology of each one of these category. And then we talked about the risk factors that you should survey in your history, and then we talked about the main clinical features, including symptoms and sign. As I have said, symptoms mainly or can range between discomfort, heaviness, and some burning and distressing pain, in addition to itching, while the signs include lipoddermatic sclerosis, swelling, eczematous features, and hemosiderosis, pigmentation, and eventually the patient might develop ulceration, and some patients they can develop some degree of ischemia. So this, yes, this is about here. In any ulcer, long-standing ulcer, if you get a suspicious swelling, then you need to rule out the possibility of malignancy. Yes. Now I will move to talk about thromboembolism, venous thromboembolism, or embolization of veins. And this usually, it can actually occur in the upper limb, but it mainly involves the lower limb. Mainly it involves the lower limb in most of the cases. This thromboembolism can affect the superficial veins. You get, and this is known as superficial thrombophlebitis, and it can affect the deep venous system, in giving rise to a common condition that we know as the deep venous thrombosis. Okay. So thrombosis of the venous system can affect the superficial veins as well as the deep veins. If you remember from your physiology lectures, the Virchow law, have you heard of this law? Have you heard of Virchow law?
No.
Virchow law explains thrombosis in vessel thrombosis. Why do you get thrombosis in vessels? And actually, Virchow, which is a great scientist in medicine, put three reasons, and these reasons collectively they are known as the Virchow law. So either you get an endothelial injury into the endothelium. This can result into thrombosis, and the classical example here is atheroma. You know, atheroma. Atheroma is deposition of fats in the subintimal layer. When they rupture, they give rise to rough surface, and this rough surface may initiate thrombosis. So endothelial injury for any reason can result into thrombosis into vessels, whether veins or arteries. Stasis. When you get stagnation of blood, this is another important reason which might result into thrombosis or embolization. And the third condition is thrombophilia. Yes, and the third condition is thrombophilia. Thrombophilia indicate that the blood have got tendency to thrombose. For example, patients who are taking contraceptive pills, because contraceptive pills they result into alteration of the normal clotting mechanism. Patients who have got malignancy or cancer, they are more prone to develop of this thromboembolism. Patients who have got loss of protein C and protein S, they are more prone to development. The patient who have got increase in number of platelets, thrombocytosis, for example, they are also prone. So Virchow's law indicates describe three main reasons for thrombosis inside the vascular system, whether veins or arteries, either endothelial injury or stasis or thrombophilia or increased tendency of the blood to clot. So out of these three reasons, which one you think is more important in the venous system, and which one is more important for arterial thrombosis? So for venous thrombosis, yes, stasis. For venous thrombosis, stasis is more important than the other reasons and the other factors. While in case of arterial system, endothelial injury is more common than the other factors. So stasis here in the clinical practice can be exemplified or can be described in patients who don't move, for example, for a long time, whether they are unconscious, whether they are bedridden due to وعليكم السلام ورحمة الله. أيوة معلش عندي محاضرة بس. So whether they have whether they are not moving for a long time after surgery, for example, or they are bedridden because of abnormal level of consciousness or so on. So stasis in general accelerates or results into venous thrombosis. And yes, and these are just giving you more examples under each of one of these categories. Immobility, as I have mentioned, is one of the important factors which result into stasis and venous thrombosis. This can be secondary to surgery, pregnancy, particularly if the pregnancy and perfume is complicated, obesity, varicose veins, and heart failure. All of these conditions can result into stasis and result into venous deep venous thrombosis. Thrombophilia.
دكتور البريجنسي كيف يسبب ستاسيس؟
Pregnancy, because of the graviduterus. Graviduterus will impede or prevent the normal blood flow or disturb the normal blood flow from the lower limbs toward the heart because of the graviduterus. Okay, it will press at the level of the pelvis on the major veins draining the lower limbs, and this can result into stasis in the lower limbs. And this stasis can result into thrombosis. Is that clear?
Yes, clear. Thank you.
Not only pregnancy. If you have got, for example, a tumor in the pelvis, a tumor in the pelvis can also result into obstruction or disturbance of the normal blood flow from lower limbs to upper limbs. So again, can result into varicose, into sorry for deep venous thrombosis. Okay. Now, regarding the clinical presentation, of deep venous thrombosis, the symptoms is usually, or the patient present with calf swelling and pain. The patient usually presents with calf swelling and pain. This is bilateral in 30% of the patients, or in 1/3 of the patients. This is usually bilateral instead of unilateral, and this is important for you as a physician to differentiate between leg swelling due to venous disease and leg swelling due to other conditions, for example lymphedema, as we will see in the next lecture. Some patients present with low-grade fever. They complain of low-grade fever, usually low-grade fever. Usually those patients, they don't experience high-grade fever. And some patients, they present from the start with symptoms of pulmonary embolism. One of the most catastrophic complications of deep venous thrombosis that an embolus which is formed in the deep venous system in the lower limb might dislodge and travel up towards the heart, and they go inside the heart, and then they close the pulmonary arteries. They close or occlude the pulmonary arteries, and this condition is known as pulmonary embolism, and it's quite serious and fatal condition. So the patient might present with, for example, tachypnea and dyspnea. When he has history suggestive of deep venous thrombosis, then you might think of pulmonary embolism. Some patients, they present with pulmonary embolism from the start, without going through the classical period of leg swelling and pain and so on. Okay. Yes. So these are the most important clinical symptoms related to deep venous thrombosis. Regarding the signs, of course, the leg will be swollen. And it may appear erythematic, and it may appear red in color. We call it a cellulitic leg because there are two things: there is swelling and there is redness. So there are two features of inflammation. And actually, cellulitis is one of the most important differential diagnoses of deep venous thrombosis. Okay, so you need to put that into your mind if you are dealing with a patient who has got a leg swelling. That deep venous thrombosis and cellulitis, which is inflammation of the skin and subcutaneous tissues, are the most two important differential diagnoses for that patients, and you may get also overlap between the symptoms and signs. So both patients may present with pain, both patients may present with fever, both patients may present with swelling. Okay, so a differential diagnosis is cellulitis. Okay. When you palpate the calf or the lower limb or the calf, you get some tenderness, probably or perhaps because of the swelling. The calf muscles will look stiff because of the swelling rather than soft as usual. And you may get also some dilated superficial veins, and this is again here because of the obstruction of the deep system, which result into dilatation of these superficial veins. And classically, those patients also develop edema. And edema of venous disease is characteristically pitting. Okay. There is one physical test that used to be done, in which you extend and dorsiflex. You extend and dorsiflex the foot in the affected lower limb. If the patient felt pain in his calf muscle due to this excessive dorsiflexion, this sign is known as Homan sign. But nowadays, this Homan sign is not recommended to be done because here there is a hazard that this extension of the lower limb and dorsiflexion might dislodge a thrombus which is found in the vein. If this thrombus dislodged from the vein, it can travel to the heart and cause pulmonary embolism. So there is a risk actually in doing this or eliciting this Homan sign. So currently it is recommended that you don't attempt to do this test or to elicit this sign. Okay. Yes.
دكتور
So this one, yes.
وش معنى وايت ضمن cyanotic؟
Yeah, text here regarding
صوتي قطع يا دكتور. ما طلع.
يقطع ما سمعنا شيء ابدا.
معلش يمكن النت بس النت ايجو يضعف شويه. Okay. So regarding this white and cyanotic, when you get first of all swelling in the calf muscles or swelling in the leg, then the blood flow will be low actually, of course, and this will result into this whitish color. This is known as phlegmasia alba dolens. This white color, which you can see, is known as phlegmasia alba dolens. After that, you get accumulation of deoxygenated blood, which result into some degree of cyanosis, and this cyanotic tint or cyanotic color is known as phlegmasia alba, phlegmasia cerulodolens. Okay, so this white color and this bluish color, these are two states which you might encounter in the swelling of due to venous thrombosis, and these are known as phlegmasia alba dolens to the white color and phlegmasia cerulodolens for this cyanotic or bluish color. Okay, but this usually is seen in patients who have got fair skin. If you are dealing with a patient who have got a dark skin, then you will unlikely be able to see these two states of the venous dilatation. Is that clear?
Yes, clear, thank you.
يعني دكتور يصير مثل في swelling بعدين will let the blood return to the heart. هذا it's called what?
Sorry, again please.
Is if there is swelling that will like stop the blood return to the heart. It's called what?
If the blood is not, if there is a swelling.
Yes, that
there is a swelling
affecting the blood return to the heart. It's called what?
Yes, if there is ايش اخر كلمه قلتها لو سمحت؟
Affecting the blood return to the heart.
Yes.
هذه يسمى وايت صحيح دكتور؟
No, actually, you're talking about this about phlegmasia. First of all, you get venous dilatation, you get venous swelling, and this swelling will affect the blood flow in the lower limb. I'm talking now about the arterial blood flow. Okay, if there is a swelling, then the blood flow into the arterial blood flow into the leg will be less. This will result into white color because of reduction in the amount of blood flowing to the lower limb. This white color here, this stage is known as phlegmasia alba dolens. Okay, and after a while, the blood which is stagnant in the lower limb, it will be deoxygenated because it's not flowing normally. Blood is not flowing normally to the lower limb, and we know that any blood which is stagnant for some time will be deoxygenated. Oxygen will be extracted from it, and this will result in some cyanosis. Just like when you get cyanosis for decreased blood flow for any tissue. Okay, and this cyanotic tint or cyanotic color is known as phlegmasia alba. So the primary problem here that the venous congestion will impede the arterial blood flow into the lower limb because of this venous congestion, resulting into this white color and then cyanotic color. The venous thrombosis can cause varicose veins. And I said here you can get what here dilated superficial veins. These dilated superficial veins is due to obstruction of blood flow from the superficial to deep system. But in acute cases, varicose veins need some time. If this obstruction in the deep system is for a long time, okay, or chronic obstruction, this can result into varicose veins. While if this obstruction is acute, it can give rise only to superficial veins because formation of varicose veins needs some time. Okay. Yes. So here, those are two patients who have got venous congestion, or venous swelling. You see the legs are swollen here in comparison to the normal side in both pictures. Here you can see some whitish color. I don't know whether you can see that or not. Some whitish color here among this, and you can say that this is some degree of phlegmasia ceruledolens, okay, or albadolens, sorry. And here you can see some degree of bluish discoloration. If that is clear, I'm not sure whether it's clear or not, but if you saw this cyanotic picture, then this is most likely the stage of phlegmasia ceruledolens, okay. Yeah, so the most important thing is that, first of all, is the leg swelling, and the dilated veins which are found on this swelling. And then the patient will most likely have a predisposing factor, like, for example, being immobile in bed for a long time, or he had surgery, for example, in the couple of days preceding this presentation, or he has cancer, for example, or any cause that result into thrombophilia. So in your history, you have to be very careful in surveying all the risk factors for this condition. Regarding the differential diagnosis, so as I have mentioned, leg cellulitis, which is due to trauma usually of the leg. And cellulitis is inflammation of the skin on subcutaneous tissues. It gives rise to a picture which is very close to deep venous thrombosis, and based on the history and the scenario and the trauma and all the things, you should be able, and doing investigation, you should be able to differentiate between cellulitis and deep venous thrombosis. Other differential diagnoses include trauma, which might result into calf muscle hematoma, or ruptured plantaris muscle, or thrombosed popliteal aneurysm, arterial aneurysm. All of these are rare, actually, are differential diagnosis, but is rare than the cellulitis. So I would say that the most common two conditions are deep venous thrombosis and leg cellulitis. Okay. So that was the last slide in the presentation. So what we have done in this lecture, that we have talked about varicose veins, their definition, their classification, their clinical features, and we talked about the deep venous thrombosis and its clinical features. So please, before moving to the next lecture, if you have any questions, please do point to me. Please do point to me if you have any questions. If you have any question, yes. If you have any question, please do point me as I prepare myself for the next session.